And we really work together, and she only does MSN, so you can really specialize if you want. Now, I put an epidemic, a new management approach, and novel therapies because there's a lot of new things on thyroid cancer. We're not going to cover everything. But first of all, it is an epidemic because with the thyroid testing that we're doing right now, we're overdiagnosing a lot of these things, and I'm just going to move on this slide. So again, what is the potential problems on the thyroid, and why do you want to know about thyroid disease? Because you want to see if there are structural problems, nodules, boulders, cancer, functional problems, hyper, and combinations of that. So most of the thyroid cancer patients present asymptomatic. So a lot of patients feel that I knew I had something. I knew this was going on for a long time. And take it very subtle because most of these things are given. Now, what we do know on the literature that patients with Hashimoto's disease have a little bit of increased chance of thyroid cancer, and I think the symptoms are more of the Hashimoto. And the diagnosis of Hashimoto's is made with the nodule, which has cancer, and then we put everything on the same box, and then we say, yes, the patient was feeling bad because of the thyroid cancer. The thyroid cancer does not give you any symptoms. This is a huge lump compressing on your trachea, which is very unusual. So 50% of adults have thyroid nodules. 90 to 95% of these nodules do not have cancer. Now, goiters, yeah, you know, the size of the normal thyroid, big thyroid, outside of the normal size. So it's symptomatic, and it's usually a lump on their neck or something that we discover by doing a CT scan after a monoplate accident. It does not cause hyper or hypo, no. It does not give you pain. So patients who come to your office and say, I have pain on my neck, is not thyroid cancer. It could be a thyroiditis. It could be a postpartum thyroiditis. It could be anything else but a cancer. So you're like, really? Okay, sit down and hold. And again, the diagnostic procedure of choice is the FNA. So this is what I was talking today. The colloid is pinkish, watery stuff inside. And then you have the follicles, which are lined with the follicular cells. And those are the cells which make thyroid hormone. Now, the most common thyroid cancer is called papillary thyroid cancer. And we're going to see some slides about that. The second most common is called follicular thyroid cancer, and very rare it's anaplastic, but all of three of these cancers arise from follicular cells, which are lining those areas of colloid, which are making the thyroid hormone. Now, on the thyroid, there's also some cells that are called the parafollicular cells, or C cells, which could give rise to medullary thyroid cancer, which is a familial type of cancer, and it's on the category of the neuroendocrine tumors, because it makes this calcitonin, which calcitonin on a high level, which is obviously abnormal, give you hot flashes and all sort of diarrhea and other symptoms that you don't have on the other differentiated thyroid cancer. So the main category is that differentiated thyroid cancer. So if you have differentiated thyroid cancer, this has not talked about prognosis at all. People say differentiated sounds good. This is BTC, 80%. FTC, so follicular thyroid cancer, 10%. Then you have anaplastic, really bad prognosis. I would say these are 5% of the cancers of the US. These patients die within 6 months. Very, very bad. So if you get an anaplastic thyroid cancer, you have to do anything you can to call the physician that knows about this the same day. At Memorial Sloan, where I trained in New York for thyroid cancer, They have an emergency system in place, and they have an on-call system for these patients. And there's always somebody covering that service, because a patient who comes to Memorial Sloan with a diagnosis of anaplastic gets workup, admission, all the same day. They get airway obstruction very easily. They die from gasping air. This is very bad. So these are the differentiated thyroid cancers. Hopefully, these are, hopefully you don't see many of those. I've seen a few, because that's my area of specialty, and they are very bad. Now then you have the medullary thyroid cancer, which are from a different cell. So they come from C cells. This is follicular cells on the differentiated follicular cells. This is C cells. They happen to be on the thyroid because on the early embryonic period they migrate to the thyroid and they stay there. They have nothing to do with the thyroid. So these C cells, medullary, this is usually a familial syndrome, and it's associated with something that's called RET mutation. So if somebody has medullary thyroid cancer, you have to do the genetic testing to see if they have the RET mutation. If they do have the RET mutation, you have to test the whole family, because you need to do prophylactic thyroidectomies on little kids, siblings, etc. If the patient has non-familial medullary thyroid carcinoma, then you stop with the patient on the treatment. So, this is what I just said. There's also thyroid lymphoma. Thyroid is a lot of lymphocytes, and Hashimoto's thyroiditis is called lymphocytic thyroiditis because those lymphocytes get inflamed. And it's very rare. It also presents like the anaplastic. So the word questions for endocrinologists is usually, is this patient having an anaplastic versus a thyroid lymphoma? Thyroid lymphomas have better prognosis because they respond to chemo very well, very quick. So these are some cases, 74-year-old women. See the trachea is here. It's all shifted to the right? Because this is a CT scan, so we're looking, this is right, and this is left. So it's all shifted. This is the big mass. See the big mass here? The patient was breathing normally. And look at the airway. So for a patient to tell you that they're not having air, you have to have a mask like that. And I'm just telling you so your anxiety goes down. Because the patient could make you very nervous. And could tell you, I can't breathe. I feel like something's choking on my throat. You do your exam, you find the normal thyroid gland, you start thinking on other things. Don't confront the patient. Don't tell them it's all in your mind. And you tell them it's probably not your thyroid. We're going to investigate other causes. We're going to do an ultrasound. So this is anaplastic. I'm just going to put one slide there. Nasty thyroid cancer. Patient presenting with hoarseness and stridor. See, these cases are urgent. These are typical cells seen on the FNA, spindle cells, giant cells. There's guidelines on the American Thyroid Association. And again, the life expectancy after diagnosis is about 6 months. Medullary thyroid cancer, so I'm doing the rare cancers first because then we're going to focus on the capillary and the other one. These patients could present with diarrhea, flushing because of those high levels of calcitonin made by the C cells make these patients sick. So if you have patients with flushing, and when you start studying neuroendocrine tumors, one of your differential diagnosis is going to be medullary thyroid cancer, and you have to rule that out. It's easy, calcitonin, measure calcitonin, and you're done. that's the way the medullary thyroid cancer is seen. Well, I'm not going to spend much time on this because we're going to go to the treatment of this one. And this is sporadic or familial, and if they're familial, they're part of the syndrome which is on MEN2A and 2B, and they have MEN2A, which is the most common. They have pheochromocytomas, they have medullary thyroid carcinomas, and they have primary hyperparathyroidism, which is foreground hyperplasia. This is usually a work question for us all the time. What are the symptoms that are associated with MEN2A? MEN2B happens usually on kids, pheochromocytomas, ganglioneuromas, which are on the tongue, and then the kids have like a Marfanoid habitus. And this is the red protoncogene mutated, and there are so many variants of medullary thyroid cancer because of the mutation that we have. So I follow 2 families right now with medullary thyroid cancer, and I just got the 3rd one. One of the families have a very aggressive mutation, and the index patient, so the patient who discovered this is the mother of my patient, who's in the 50s, who had thyroid surgery at MD Anderson. It's all lymphadenopathy and very advanced thyroid cancer. I recommended a prophylactic thyroidectomy, and she already had an 8 millimeter medullary thyroid cancer, but I think she's cured. And her 2 kids had the mutation. So we now have to decide when to do their prophylactic thyroidectomies, because it's very hard to regulate thyroid hormone when they're kids or when they're teenagers, so we're trying to see what's the best recommendation for those kids. And then I have another family who also have a lot of family members that are dead. So know that this exists, that you have to send it to a geneticist and then work with an endocrine doctor. See, depending on the mutation, you need surgery when they're less than 6 months old or when they're less than 5, depending on how aggressive is the mutation. And there's guidance for that. So the American Thyroid Association website is really friendly. And if you have patients that question you about everything, we have guidelines and what's the standard of care. And so you don't go and tell the patient things that you think, but you're not totally sure. You know, they come on armorethyroid, which is a desiccated hormone, and you tell them, yeah, I agree to work with you on this type of thyroid hormone, but the guidelines suggest this one because of that, that, and that. So have that guidance on your mind. They're easily accessible for everybody. So most of the thyroid cancer are papillary thyroid cancer. And I think I hate this wording of, if you have some cancer, thyroid cancer is the one you want to have. I hate that, because there are some thyroid cancers that are bad. But the course, it's usually slow. It progresses very slow. So it arises from those follicular cells. Females, many more common on this, 2 to 1. So when you have that ratio, so be careful when you have a practice that has a lot of women. It goes and metastasizes to the lymph nodes on the neck. So the first thing you need to know when you have a patient with a thyroid cancer, and you confirm that with your FNA, is to assess the lymph nodes to see if that patient on the same surgery needs the thyroid out and the lymph node out. Because if not, that patient is going to be buying 2 surgeries instead of 1, because later on they're going to find that lymphadenopathy was there. It makes something that's called thyroglobulin. So thyroid cells, normal and malignant, make a big protein that's called thyroglobulin. And that's, I mentioned that because that's my tumor marker that I have, which is not perfect because it's also made by benign cells, but it's what I follow on patients that have thyroid surgery, plus minus radioactive iodine. So if you look at this picture, see how the papillas are being formed? See, you don't see this on the FNA. You need tissue for that, because you need to see how the cells are rearranged. On the FNA, you just see one of those little cells, and diagnosis of papillary thyroid carcinoma is after the nucleus, how it disposes the chromatin and the overlapping of the nucleoli and all that stuff. So this is a picture of a thyroidectomy. So see these cells, these are the follicular cells which are clearly abnormal, lining and forming this papilla, and that's the name, papillary thyroid cancer. So normal, unusual presentation, it's a painless lump. See this, it's very suspicious. Calcifications, the borders are not clearly defined, it's hypoechoic, so it's dark compared to the thyroid parenchyma. And then you do an FNA and you get these papillae again. All these little structures here. So, any questions about papillae? The most common, mostly in women, in metastasize on the neck. The second most common, but really the percentage goes down to 15%, is follicular thyroid cancer. It's a little bit more aggressive, and it does not metastasize on the neck. This goes outside. Lungs, bones, brain, etc. Now, prognosis of these tumors is usually good when it's caught at early stages. But I see a lot of patients with history of follicular carcinoma, and they come to my office and they have like 30 ultrasounds of the neck, and I'm like, you do not need that, because these, we're never gonna find that. They're reassured, they're like, yeah, you're fine, I don't see anything wrong. You're never gonna see any abnormal lymph node metastasis. Never. Maybe 10% of the cases, 5% of the cases, and those are the cases that are really advanced. What you see is, you know, growth of persistent masses on the neck, which is not lymph nodes. So what's the treatment for thyroid cancer? And I'm going to try to make it simple for you, because usually I do this conversation with the patient, but patients may have like a waiting time of a month to get into my office, so then you're going to deal with a lot of questions at the beginning. If you have a patient with thyroid cancer, the first treatment is surgery. And the second treatment is surgery, and the third treatment is surgery. This is a surgical treatment. Now, there's a lot of controversy what to do with surgery. So, lobectomy, you only take half of the thyroid, or total thyroidectomy. If you do a lobectomy, then you know that there are no lymph nodes that are abnormal, because if not, you need to give this patient radioactive iron, and we'll talk about that. If you do a lobectomy, the tumor usually have to be less than 4 centimeters. And that's what the guidelines say. You can have any discussion with the patient. You can have a patient with a 5 centimeter tumor that wants the lobectomy only. And as long as you document, they agree with that, and they are aware of the risk, then the patient is the owner of the health. So you can discuss this. Same, you have patients with a 2 centimeter tumor that they want everything out. And despite telling them complications are higher and everything. So if it's more than 4 centimeters, you do a total. If it has lymph node metastasis, goes for a total. Or if it's an aggressive variant. Now, why are we trying to be as less aggressive as we are? Because if it's an encapsulated thyroid cancer and you do only a lobectomy, the risks of complications are much lower. And the two main complications of thyroid surgeries are, can you see that? So the main complications of surgery in thyroid are 1, vocal cord paralysis. So always you need to know who's your surgeon, and if you don't know, you call your endocrinologist close to your area and you ask them who to send those patients. And we're really trying to do this because we don't want more patients with complications. When you have your thyroid gland, and you have your trachea and your larynx, the recurrent laryngeal nerves run really close here. Just try to be graphic, it's not exactly like that. So they're usually not recognized by the surgeons who are non-experienced and they're dissected. So if you cut one nerve, you have a unilateral vocal cord paralysis, right? So what happens with that? The patient is hoarse, so they come to your office and they can't talk. Sometimes it's transient, but if it's permanent, then one vocal cord is not moving, right? So it's always open. So you don't go to the midline to do it to make up your voice. They aspirate liquid all the time, which goes into the wrong way. I mean, it's poor quality of life, right? And I have a few of these patients, unfortunately. Now, sometimes the surgeon tells the patient, your tumor is in the recurrent laryngeal nerve, you're going to lose your voice. Or the patient presented with a vocal cord paralysis because the tumor was growing into that area and paralyzed the vocal cord. Now, if you have a bilateral vocal cord paralysis because the surgeon snapped the two nerves, this patient needs a trachea forever. So, know who's your surgeon, because if you do that and your vocal cords do not move on the center, you're not going to be able to breathe or swallow forever. And I have a lot of patients with tracheostomies in my office because these were aggressive thyroid cancer or these had to need a resection, but I've seen a few problems like that. Because if you cause a unilateral vocal cord paralysis because you snapped the rib, and then in 2 years the patient had a lymph node that's growing here, whoever takes and dissects this area is very brave. Because you're really close to leaving that patient with a tracheostomy permanent. So, be aware of who are your surgeons. Number 2, hypoparathyroidism. So, the calcium and PTH metabolism and everything is very delicate. So, if you have your neck, you have 4 little glands right here, which are the parathyroid glands. They make PTH. PTH goes into your bones and sucks out calcium out of your bones and the equilibrium with the blood calcium and all that stuff. I don't know if you guys saw that already. Okay, so if they take a normal parathyroid gland is the size of a grain of rice, so surgeons do not see those. You have to be very experienced. So if you get a lobectomy only, you go down on the complications, right? Because if they take 2 of your parathyroid glands, you still have 2. And if you get a vocal cord paralyzed, you still can breathe and do not get a tracheostomy. So we try to recommend to the patient to be less aggressive, because then it's hard to live with these complications. Yes?
In patients that get lobectomies, do the parathyroid glands that are left, like, and the thyroid, like compensate for what was lost?
Well, that's a good question. Most patients with two parathyroid glands live a normal life, and they compensate. Some patients need some help with calcium, but it's not the same as having a complete, profound hypoparathyroidism. Then if you don't take your calcium, which is high amounts of calcium and vitamin D, you could really die. Now, some surgeons take the thyroid out, and then the pathologists tell them there's a parathyroid and another parathyroid on the specimen, so then they re-implant them. So after some ischemic, change, they reimplant the parathyroid glands, and some of those partially work. So that's why you need a good surgeon, and that's why you have to be the less aggressive as possible. Well, there are cancers that need a total thyroidectomy. And before the 2009 guidance, all the treatments, all the recommendations were do a total, and then we know when overdoing things or giving more complications. And I'm telling you, it's not fun to live with hypopara. It's really. Also, if you do a partial and the patient has a normal, healthy contralateral lobe, they may even not need thyroid hormone. That's another plus, which is very important. And what else? And I think that's it. Now, when I follow these patients, my follow-ups are usually neck ultrasounds every 6 months or a year, and something that's called thyroglobulin. So, before going into that, let me tell you about radioactive iron so we can understand better how to follow the thyroglobulin. So I put on my last lifelong monitoring with plasma thyroglobulin and neck ultrasounds, and this is what I'm going to talk about. So some patients need, this is all what we talk, the risk of recurrent laryngeal nerve damage, parathyroid glands. This is radioactive iron, but I think I have more. So how does radioactive iron work? If I want to give patient a radioactive iron dose, it's because I want to kill all small metastases, micrometastases that the surgeon was not able to see when he was in the OR. So the same concept. The thyroid uses iodine as a food, and we add an isotope, iodine 131 in this case, and these cells take up iodine and they are killed, essentially. So the radioactive iron is supposed to kill every normal cell that has left on the thyroid bed, that stays there, and a lymph node with a spot of thyroid cancer, right? That's the hope. It not always works this way. And not every patient needs that. We stratify the patients and we say, okay, this is a patient at high risk of recurrence, and we're going to give them a high dose of radioactive iron. This is a patient with a low risk of recurrence, and we're not going to use radioactive iron because the chances of having a recurrence of this, it's about, 2% or something like that. So, when I want to give them radioactive iron, I want to make the patient swallow that pill, and then they irradiate that for about 5 to 7 days. Have you heard about that? They're going quarantine or isolation. It's because if you have little kids at home or pregnant ladies, you can't be close because you may destroy their thyroids. So after 7 to 10 days of the radioactive iodine dose, we do what's called a whole body scan, and they do a scan, head to toe on the patient, and see this patient has a lymph node with plenty of metastasis, and that's highlighting. And GI uptake is normal. There's lung uptake. This patient probably had some, lung spots, and those spots are being killed by the radioactive ion. This is a lot of lung uptake, a lot of lung metastasis. Metastasis on the right iliac bone, so that's how you see a whole body scan. Now this is a normal scanning on a patient who doesn't have metastasis outside the neck. It's called star effect. This is just killing normal cells that are left on the thyroid bed, that's all. So this is good. The star thing, it's good. So once I killed everything, I'm not supposed to have any cells making thyroglobulin, right? So that level so a patient who underwent total thyroidectomy plus radioactive iodine, the thyroglobulin should be 0 or less than 0.2, which is the lowest resolution of the test. Right? Not every patient is there, and doesn't mean that they have cancer, and patients really want this number to be 0, but so we are going to aim for that, and when we have these, after total and radioactive iodine, we call excellent response to therapy. Now, some patients underwent lobectomy only. So your thyroglobulin is coming from the contralateral lobe, and it's normal up to 30, sorry. Nanograms per dl. So it's not a good test to follow thyroid cancer, because if you have a lymph node metastasis later on, or a small, you can have this number 1, 2, 3, 4, 5. And the ultrasound becomes your best test. And then you have patients who underwent total thyroidectomy, but no radioactive iodine. So they do have a detectable level of thyroglobulin, which is between 2 and 5 or something like that. And they don't have thyroid cancer, but they have detectable thyroglobulin. So, once I have the patient on my office for 5 years and I see these, I send those to the community. So you're going to get these patients, because I cannot take care of all the thyroid cancer. I'm taking care of the risky patients. So you're going to get these patients alone. The patients who have an excellent response to therapy, and they have a remote history of thyroid cancer, and they have no evidence of disease for 5 years, they're going to become your patients. At Memorial Sloan, where I train, they call the survivorship program, and they have somebody for that. Here we don't have that. I'm trying to build one, because even though there are patients who have thyroid cancer in the past, it becomes complex for the physicians who are taking care of them. But these patients aren't going to end up on, and some patients are, you know, I don't even know that I need to follow with my endocrine doctor. It's the copay is high, you know, different things that come up. I moved to another state, and do I need to establish care with a new endocrine? So those are the patients that you're going to follow. So on thyroid cancer, and I'm here giving you the excellent response to therapy. The others, like biochemical incomplete, means that they have a detectable tumor marker, or structural incomplete, that they have some piece of thyroid cancer, should not be followed by a primary physician. These patients need to be followed at a specialist office, either a surgeon or an endocrine specialist. So what's the mortality on thyroid cancer? Let's see if I have a slide. Okay, here. So this is one of the landmark studies that appeared when we started to know that the thyroid cancer was becoming an epidemic. And we were not even thinking of giving a talk to PA students at that time, because these would be diseases that we would follow. But nowadays, we have about 60 to 70,000 cases of thyroid cancers in the US every year. So with that high rate, there's no endocrine doctor that could follow all these patients. So you're going to get these patients for sure. So if you take a look at this slide in 1973, look at the rate per 100,000 patients that have thyroid cancer, and look at the year 2000, how this went up. But the mortality rate remains flat. So we're detecting very small thyroid cancers, and we're not helping the patient. We may give them vocal cord paralysis and hypoparathyroidism, but we're not really improving their life expectancy, because it was going to degrade anyways. So, on the same study, the line really follows the detection of papillary thyroid carcinoma. That's the one that went up significantly. And why is that? Because on the slide, on this graph, you could see that the line really goes up on the tumors that go from 0 to 1 centimeters. We should not biopsy, right? We should not biopsy 1 centimeter nodules or less. So we're trying to avoid this. We're trying to do unnecessary treatments on patients. This keeps going up and up and up, and this is a problem that it's going to be hard to fix. So 87% of the increase is due to primary tumors less than 2 centimeters, 49% is due to primary tumors less than 1 centimeter. So this is a huge number of patients that are being diagnosed and we're not helping. So this is a study that is also really remarkable. In Korea, as part of the screening for cancers, they have included a thyroid ultrasound. So pap smear, mammogram, colonoscopy, and now the thyroid ultrasound. And look what happened. The green line way on the bottom, I don't know if you guys get to see that, it's the mortality for thyroid cancer. So no meaning how many more cancers you can detect at different stages, the mortality remains almost flat. So that's what I was trying to emphasize. Don't overdo things because you're not helping the patient most likely. And again, this is the adults being screened for thyroid cancer. So that's why thyroid ultrasounds are not approved as a political thing to improve thyroid cancer detection, because we're not achieving anything. We're just having more anxiety, more testing, more expenses, and we're not really doing anything. You know, mammograms decrease the risk of mortality on women, pap smears on uterine cancer, not for thyroid cancer. So now, since 2014, thyroid cancer has become the most commonly diagnosed cancer in Korea. So, do we need to see all this iceberg here? Do we need to see the occult papillary thyroid carcinoma that millions of Americans, the studies, autopsy studies have shown that up to 30% of adults have evidence of some spot on their neck with thyroid cancer. This is really high. I mean, 30% of us have thyroid cancer. Not sure who we are, but it's a true rate. And this is because of the ultrasound and the CT scan and the overdoing of the PET. So, is detection and immediate treatment of very low risk thyroid cancer helpful or harmful? We think it's mostly harmful. So use common sense, of course. So this is what I just told them. I told you about thyroid surgery, radioactive iron ablation. Now there's a lot of how you have to suppress your thyroid. Now, if you think about it, the first graphs that I did about the thyroid, if this is the pituitary making TSH, this is a thyrotropic hormone. So, we think, and this is being shown, that if you have a thyroid cancer spot and you don't have the thyroid anymore, but you have a small spot left, this responds to TSH. So the highest is the TSH. This is going to grow, right? This pen can't do that. So on patients with thyroid cancer, we used to give them lots of thyroid hormone, LT4, to shut this and not see that. And that's called TSH suppression. And then we saw that we were giving a lot of patients osteoporosis and AFib, atrial fibrillation, and arrhythmias from having this thyroid hormone level very high. And then there were groups in the US that started to study, does it need to be TSH suppressed every thyroid cancer in every patient, for how long? So we're really not suppressing any longer. And patients love TSH suppression, they feel better. They like thyroid hormone, it's a boost of energy. You know, if any one of us who do not take thyroid hormone, the higher is the level. It's like taking, what is the energetic drinks that you guys have? Yeah, something like being on that all the time. And you feel energetic, and it's a subnormal state. We would all feel better. So we're trying to talk the patients away from that. You do not need TSH suppression, except the patients who are at high risk of recurrence, which are not going to be followed by you. Those patients need to be followed by specialists. And I'm really close, tightening the dose and having, but at the same time, once in a while, I have a patient that I feel. And I hate that, because you could die from a rapid AFib. And it's scary. So I'm giving too much suppression to a patient that really the life expectancy is very long. So it's complicated, but most of the patients who are followed in the community with thyroid cancer do not need TSH suppression. You just keep the TSH within normal range. They try to talk you into this, all the patients. Well, my previous endocrinologist kept me suppressed for 15 years, and now you're just all of a sudden telling me that I don't need a suppression. And yes, I'm telling you that. You do that very slowly. So somebody who has been suppressed for 15 years, you can go from 200 to 100. Never do that. Never half the dose. If you don't want a patient in your office, then that's the right thing to do. Never do that. Always baby steps. If you go from 200 to 188 for 3 months, the patient's not even going to feel that. And then in another 3 months, go from 188 to 175, and you do that very slowly. Because then you're not going to even see how to interpret the results. Especially if they lived suppressed for a long time. So, papillary microcarcinomas, which are the ones who are now offered active surveillance, it's based on this, because less than 1% of these patients die. Metastasis on 2%. Distant metastasis, I haven't seen any, but it says 1%. And that's why Japan started to offer this to their patients, and now it's brought to the US. And there are a few universities that are offering this on a common daily basis. I'm doing that in Oklahoma. You have to talk to your surgeon, have to talk to your patient, make sure that they're not. But look at the disease-specific mortality. So less than 1% on active surveillance at 10 years. So patients who have not had surgery, and you just watch a microcarcinoma, they're doing just fine. They need to be watched though. What's the risk of metastasis? 2%, 1%, 1%, distant metastasis. So these patients didn't need any surgery to begin with. In all cases, the first therapy was very effective. So these are the guidelines, and I again go back to the guidelines. This is a supportive decision by the guidelines. It's becoming the standard of care. So the traditional paradigm in the past was one size fits all. We did total thyroidectomy, radial ablation, and TSH suppressor for every single patient, and now we're doing a more defined and risk stratified patients. Low risk don't need it, intermediate risk maybe, high risk they do need all that stuff. So it's called a risk adaptive paradigm. So they have we box the patients onto these three categories, and that's what I do all day on my office. Try to fit the patient on every box, and I do that every time because a low-risk patient will now develop a lymph node metastasis change to high risk, and I'm going to treat that patient differently, and I'm going to have that patient come back to my office in 6 months instead of a year. So I do these boxes all the time. And then it tells you what is a low risk. No lymph node metastasis, everything encapsulated. Intermediate risk could have some microscopic metastasis. High risk, aggressive histology, distant metastasis, and so on. So this is the line, and it's a continuum, so it's not had a clear cut because it adds up the risk, and we're not entirely sure. But see on the percentages here, you have what's the risk of recurrence. So a follicular thyroid carcinoma on the top with extensive vascular invasion has a 30 to 55% risk of recurrence. And I tell that to the patients, your tumor is high risk to recur, so I'm going to follow you closely because 1 out of 2 patients have a new spot of thyroid cancer on the next follow-up appointments. So you prepare them mentally. As opposed to if I have on the bottom, a unifocal papillary microcarcinoma, I tell them, you had a lobectomy, you're most likely cured. I'm going to follow you up every year with an ultrasound and a thyroglobulin and a TSH level, and that's all. So then, the new thing about this is, and this is the same thing, depending on the clinical course, the risk of recurrence changes over time. And every time the patient comes, I change the risk of recurrence. They may be excellent all the time, they may be different. And what's the change on thyroglobulin? What's the results of the neck ultrasound? What's the results of the radioactive iron scanning? And then I box excellent, which are these patients on the top with a thyroglobulin less than 0.2, biochemically incomplete. I see some thyroglobulin and I'm not sure where it's coming from. And then patients who have some disease on their neck, and we're following that. So this is pretty much what I do. And now I wanted to finish up with this. The main tool on thyroid cancer treatment is surgery. And some patients have 3, 4, 5, 7 surgeries for thyroid cancer. Ideally, no, that would not be ideal. And some patients have 3, 4 doses of radioactive iron, and some patients had external radiation therapy. But now there's something that's called the chemo for thyroid cancer that really came a few years ago, about 4 or 5. And there are only 2 approved drugs on the market, and one is called lenvatinib, and the other one is called sorafenib. And those are pills that patients take twice a day. They're not very well tolerated because it gives a lot of fatigue, a lot of diarrhea, and discoloration of the hands and palms. But at least we are thinking we stop the progression of thyroid cancer. None of those drugs, which both are FDA approved, have shown that you improve survival in patients. So the literature is still. Now, with all the advances on melanoma and colon cancer, we're now trying to introduce immunotherapy, and it's all in a research basis. So I send a lot of patients to MD Anderson because they enroll them on clinical trials and they try, but those are patients who have advanced thyroid cancer and they have not responded to any therapy, and now they go into this immunotherapy because now we think cancer, it's an immunological disease. So it's very complex, and there are traditional chemo does not work, and these are the mutations on thyroid cancer to tell you exactly how complex is that. You have different areas where you can block. So if you block here, if you block here, if you block here, the patients have an escape. The cancer actually has an escape mechanism, and you may respond to a medication for 2 years and then escape, and then you switch to another one. Now, I don't do that. I send the patients to the oncologist. There are some of my colleagues who do chemo for thyroid cancer. I think you need a whole setting of nurses and support to do this. and those are called the multi-kinase inhibitors. So I think I'm gonna stop here, and because then the other comes more of a, so now we've viewed the spectrum of thyroid cancer and how, broad is done, but the most common is the papillary thyroid carcinoma, which gives lymph node metastasis. We're trying to get away of the traditional management of thyroid cancer, and we re-stratify those patients on low risk, intermediate, and high risk. So not everybody needs a total thyroidectomy and radioactive ablation and a TSH suppression. We really want to do precision medicine, right? That's the last word, precision medicine. Think about a patient as a unique case. This patient needs that. His or her network is different. This patient is pregnant. This patient does not want to have a scar on their leg. This patient wants the total thyroidectomy because her mother died of thyroid cancer, so individualize. That's what you want to do now. And know that there are a lot of new things on thyroid cancer. We have not shown yet that we improve survival, but at least we're stopping the progression of the disease. Any questions? Yes?
You mentioned that you had a couple of families with children and adolescents that needed the prophylactic thyroidectomy. How does that normally affect their lifespan into adulthood?
They need thyroid hormone. We think they live as much as anyone else.
Okay.
Now, if you think about a teenager going into all the hormonal changes, it's very hard to monitor that. Because the thyroid, it's an active player on that. So you really need to do this on a team where they could follow growth and menarche and things like that. It's complex. So my preference usually is to postpone that prophylactic thyroidectomy after they're gone through at least teenage years. But if you have a high-risk mutation and they're going to have a thyroid cancer by 10 years old, then so yeah, yes.
I had a question about the medullary thyroid cancer. I noticed that the patient has an elevated CEA. Do you ever send them to GI to make sure that it's nothing to do with colon cancer or?
So I measure both, right? The number one is the calcitonin. So if my calcitonin and the CA are both high, this is medullary. Now if your calcitonin comes back normal and this is high, this is non-medullary and you send it to GI.
Okay.
Yes. But in medullary you always have the calcitonin very high. Could be 1,000. I mean, normally it's less than 2. So the problem is on the ones that you have 50, and we have a lot of stimulating methods to raise that level, but it's complicated. Any other question? Any questions about the thyroid nodules and the workup for that? No?
What do you want to see from them? If they're referring a patient to you, what do you want?
So, that's a good question. I'm going to tell you what I specifically for my clinic. My clinic is a little bit specialized. So when I have a patient that's referred to me for a thyroid nodule, I need a TSH and an ultrasound. Because with fingers, your suspicion starts there, and then you send the patient for ultrasound, and then I repeat my own ultrasounds, and I do everything myself because I have a lot of surprises. And thyroid nodules that are not real, thyroid nodules, but we need an ultrasound and a TSH. Now, if you want to follow, I expect a primary physician or a primary provider to follow sub-centimeter nodules on their own with a normal TSH. Because we said that even if they're suspicious, we're not going to do anything, right? patients are not happy with that. And they're like, well, it all depends on how you phrase that, right? Because I'm telling you, a lot of men that are 80, they don't care about sub-centimeter stuff on their neck. They're like, glad that I got, so it's like, yes, you have these, we're gonna follow that up in about a year with another ultrasound. So, to me, I get a lot of referrals of, or think about the patient. If you have a patient with COPD, CHF, who's not gonna tolerate surgery, then, and you find a 2-centimeter nodule on the neck, you stop there, because you're not going to take the patient for surgery. Just make them aware of that, but I got last week a patient with really advanced dementia on a thyroid nodule. And I'm like, if I stick a needle on her neck, it's gonna be cancer, because the nodule was sonographically high risk of malignancy. And then I'm gonna put the family on this. Then you're gonna take that patient to a total thyroidectomy. So, use common sense. I think we're practicing a lot of defensive medicine. Like, what if I'm sued? What if I'm... Talk to patients, talk to families. Disclose things. Document well. So you tell them, this is what's recommended on the guidelines, but I think for her case, because if not, you just become a robot. I think, then what's the function of a provider? We have to guide patients with all the tools that we have. And if you tell them, well, the ultrasound is this, the biopsy is this, I think for you, we're not gonna do the biopsy for now because it's not necessary, because yada yada. Even I have a lot of pregnant ladies on my office that I follow them for thyroid cancer, and I tell them, when you're pregnant, I'm not doing ultrasounds of thyroglobulin. I do not care about that. I care about you having a good pregnancy. And they become upset, and then when I explain them, but listen, if I find a little bit of growth on one of your nodules, then what are we gonna do? We're gonna put you, so don't get there if you don't wanna deal with the consequences. So don't order ultrasounds for unnecessary reasons unless you have a true indication for that. You feel a goiter? Yes. You feel a nodule? Yes. You have a normal thyroid function test consistent with a suppressed TSH? Yes. Hypothyroidism, it's a clinical diagnosis, and you just confirm that with a lab. So if we're going to biopsy and do an ultrasound on every Hashimoto's patient, then, levothyroxine is the #1 prescribed drug in the US. So how many million patients are there and they all need an ultrasound? No. Feel their neck. Whatever is clinically significant, you're going to feel that with your neck. So practice exams, touch thyroids on every patient because it's hard. And as long as you get, I think gynecologists are very good on thyroid exams because they feel their thyroids on every patient. They're on top of that. So don't order unnecessary tests that then you're gonna open up a whole box of things for patients that, I had a patient, one of my patients yesterday, she's from India, but she lives in the US. She had a 5-millimeter nodule seen on an ultrasound at an outside institution. She went to visit her family in India in May. She had a full ultrasound. Again, this 5-millimeter. They come to my office yesterday saying, she has cancer, and I'm like, I do the ultrasound and it's not even there. So I said, you probably had a cyst that is not resolved. So she has not had a good year for a 5-millimeter nodule. And she's, she has 5 kids. She's a young lady who's concerned about her kids more than, it happens to all of us. And then, did you really have something to offer to that patient? No, you're reassured. And I told them, come in about 2 years and we'll repeat the thyroid ultrasound. Or if you're really, really concerned, come in about a year. But work with them so you don't just doing what others say. They found a nodule and that person feels obligated to find it and document it and do the same thing. And I see that a lot of on my takes, I teach the ultrasound technicians, and they, if one ultrasound tech found a nodule, then all of them feel obligated to feel that which was never a nodule. So don't repeat that stuff, because just make your own assessment. Also, we often get out of time, but open those pictures. Look at that. If it's a cyst, it's a ball of a cyst, and you don't need to send that patient anyway. I'm not trying to tell you you don't never need to refer a patient. I love referrals. But there's a lot of things that you could do on your own that don't need my expertise. Because same with the thyroid testing. There's a lot of testing about free T3 and free T4 and reverse T3. And they come to my office and they're like, yeah, see, they check this and that. And I'm like, this doesn't help for a diagnosis or for a management of the thyroid medication. You just need to, follow the patient clinically. We cannot stop listening to patients, right? We're like, okay, see, your labs are that, then you listen to the patient and deal with that and try to. So that's the main. I mean, in any field you go. If you go to primary care, if you go to family, if you go to any subspecialty, if you go to surgery specialties, I think there are some surgeons that are really good on doing some clinical stuff because they're not getting common sense, huh? Common sense. Don't go over areas that are going to harm the patient rather than help. That's all.
Thank you.